This morning, I am excited to welcome Dr. Vienna Tran. She is one of our current chief residents in OBGYN. Originally from Palo Alto, California, she completed her undergraduate education at Swarthmore College, where she majored in chemistry and a minor in biology. She then went on to medical school at the University of Rochester before coming here to UW. She currently serves as an administrative chief resident and a member of the DEI committee. She believes in ensuring access to education and healthcare and has centered contributing to the community in her professional endeavors. Please join me in welcoming Dr. Tran this morning.
Good morning, everyone. Thank you so much for having me. My talk today is called From Correctional Care to Correct Care, Reproductive Healthcare in Incarcerated Patients. I first became interested in this topic through an encounter that I had at what was then called the Arboretum Clinic, now called the Resident Continuity Clinic, with patients who were experiencing incarceration. My learning objectives today are firstly to examine the history and legal status of health access for persons who are currently experiencing incarceration. Secondly, to describe the barriers to access for patients who are seeking reproductive health care, including preventive pregnancy and postpartum care, and to assess the role of the obstetrician gynecologist in providing care to incarcerated patients. We'll go through these learning objectives by first talking about background, covering several specific issues in obstetrics and gynecology care, looking at the ACOG recommendations for care in carceral settings, examining the experience of some patients who were pregnant while incarcerated, looking specifically at the issue of shackling in obstetrics patients and issues for us as providers in providing care. First, we should talk about the background. Women are the fastest growing segment of the incarcerated population in the United States. In 2019, the most recent year for which data is readily available, there were estimated to be 218,000 women incarcerated in the United States, making up 10% of the people who were incarcerated at that time. 1.8 million women were arrested in 2019, including 142,000 minors. Girls and young women make up 30% of youth who are incarcerated. It's estimated that almost 15% of people who are detained by ICE are also women and girls. The majority of these are for drug and property charges with no evidence of violence. 75% of people who are incarcerated, women who are incarcerated, are of reproductive age. And while the data is limited, it's estimated that anywhere between 3 to 10% experience pregnancy during incarceration. Some terminology before we begin. Incarcerated refers to a person who is confined to a jail, prison, or other institution. This is not a specific term related to this population, but we'll be using it a lot. Jails are facilities that are administered by city or county law enforcement. These house people who are awaiting trial, sentencing, or transfer to other facilities, or are for people serving sentences that are generally less than 1 year. Prisons are longer-term systems under state or federal jurisdiction, which house people who are convicted of felonies, generally for greater than 1 year's time. Justice involved is a term that we'll use that describes people who have had interactions with the criminal justice system as a defendant. An important piece in talking about this population, like every population, is to use accurate, stigma-free, and person-first language which prioritizes individuals over their characteristics and avoid defining people by the acts for which they are accused or convicted. Reproductive justice is another important piece for us to discuss. Reproductive justice is a framework that emerged from and centers the experiences of women of color and other groups that are marginalized by society. It promotes equitable and dignified care, including the right to have children, the right not to have children, and the right to raise children with dignity and in safety, and recognizes that social structures and institutions differently enable people or prevent people from achieving those goals. When we think about the patients who are involved, we know that justice-involved women have at the time of entry into the justice system, have an increased history of poverty. They have increased incidence of acute or chronic illness, increased incidence of substance use disorder, especially untreated, increased incidence of mental illness, higher rates of HIV and other STI infection, reported greater history of interpersonal violence. And when we look at backgrounds, we know that these are patients who often have decreased educational and employment opportunities and decreased access to healthcare prior to entry into the justice system. Unfortunately, as with many things, we know that there is institutionalized racism, which strongly affects these patients. Black women are imprisoned at about 1.7 times the rate of white women. These factors really contribute to people having at time of entry to jail very different experiences. People who are incarcerated have a constitutional right to basic health care. These 3 basic rights have been identified for patients in correctional settings. Firstly, access to care. Patients have access to specialists or hospitals when they need it. Second, ordered care, which means that treatments that have been ordered by a medical professional must be enacted. And professional judgment, which is medical care without bias due to the incarcerated status of the patient. Unfortunately, there's no mandatory standards or oversight bodies for the care provided to women, and there's significant heterogeneity of practice. Healthcare services can be provided by clinicians in the facility or off-site. Some prisons and jails provide healthcare through local health departments, others through partnership with academic systems, and others through contract with private health vendors. Estelle versus Gamble is the case that established these rights, or was one of the pivotal cases in establishing the rights that we discussed. J.W. Gamble was incarcerated within the Texas Department of Corrections and had a work injury when a bale of cotton fell on him. He was not treated for a period of 3 months, during which he reported many symptoms and was unable to access care. He sued Estelle, who was the director of corrections at the facility. And the US Supreme Court found that the government is obligated to provide medical care for those whom it is punishing by incarceration because an inmate must rely on prison authorities to treat their medical needs. And that deliberate indifference to serious medical needs constitutes unnecessary infliction of pain, which is prescribed by the 8th Amendment. When we think about the issues that are relevant to us, those are the issues that are of OBGYN care for justice-involved patients. We'll talk about several of them today, including access to care, issues of contraception and pregnancy, cervical cancer screening, transgender health, and do a deeper dive into obstetric care. When patients are incarcerated, they are often unable to access any private insurance that they have prior to incarceration. They often may also have Medicaid and Medicare benefits suspended or terminated during this time. Payment becomes the responsibility of the detaining institution, and many of them require copays to access health services. ACOG has put out a statement that they oppose copay policies in institution of incarceration due to the limitations that this places on patients' ability to access care. We think about contraception. We know that patients in the justice system have higher rates of unintended pregnancy and lower rates of contraception use. Patients are more likely to be sexually active around the time of incarceration and release, which increases their risk of unintended pregnancy. Many patients, when asked, have reported that they would like to initiate contraception prior to release. Unfortunately, we know that within the carceral system, very few jails and prisons have contraception available, even if patients have already been started prior to incarceration, and emergency contraception is almost never available. The pretty expected outcome of that is that there are a lot of pregnant patients who are in prison. As I said before, it's estimated that somewhere between 3 and 10% of people in women in prison have experienced pregnancy during their incarceration. There's a study that looks at a 1-year period at all the patients who were admitted to prisons. In these 1,400 patients, there were 750 live births, of which 6% were preterm and 30% were C-sections. 6% of these pregnancies ended in miscarriage, 1% in abortion. There were no maternal deaths and 3 newborn deaths in this study. We look at abortion access. We know that patients have limited access to abortion. There's a study looking at access within the state and federal prison system, as well as in the county jails. There's state and federal prisons, 14% of states examined in the study don't allow for abortion at all within the carceral system. Only half allow abortion in both the first and second trimesters, and 2/3 require the incarcerated women to pay for the costs of care. In the patients studied here in this 1-year period, 1% of pregnancies ended in abortion. Interestingly, they also looked at jails, which, as we said before, are places where people are generally incarcerated for shorter periods of time, meaning that people are more likely to be incarcerated when during their pregnancy, but to be released prior to the conclusion of the pregnancy. In the county jails examined in the study, 67% allow abortion in both the first and second trimesters, and only 25% required incarcerated women to pay for the procedures. In the jail studied, 18% of pregnancies were ended in abortion, likely representing the ability of patients to exit the system. Looking at other important gynecologic care, one of the populations that is highly affected by the same social determinants of health are patients who have cervical cancer. A recent systematic review looked at 21 studies that looked at the rates of cervical dysplasia in incarcerated patients. These studies all showed that patients have a higher rate of abnormal pap smear, higher rate of high-grade cervical dysplasia, and a higher rate of cervical cancer. Looking at the access within the prison system, patients have inconsistent access to colposcopy. In many cases, there's a 40 to 50 day wait for the soonest possible appointment, even following a high-grade pap smear. There's limited ability for follow-up, either within or outside of the carceral system. And patients have very poor understanding of cervical dysplasia and both poor knowledge of and poor access to HPV vaccination. We think about trans health, we know that detention facilities are among the most gender segregated of the US institutions, and the role of gender is really complex within the justice system. Housing assignments are made based on gender assignment at birth. However, sometimes patients are moved to a separate floor for LGBTQ individuals, which are often coincident with floors for people who are suffering from mental illnesses, those who have committed sexual crimes, or patients who have disabilities. Data suggests that there is a much higher rate of imprisonment for trans and gender nonconforming individuals, with 1 in 6 transgender individuals having been incarcerated at one point in their lives. And in Black trans patients, the rate of incarceration are even higher, with some estimates saying that nearly half of patients have been incarcerated at some point. Trans individuals are at very high risk for violence and victimization and have more severe health disparities before, during, and after their incarceration. Lack of access to healthcare is very common, with 20% of trans patients saying that they were unable to access the care that they needed. There's very inconsistent access to hormone treatment, even for patients who have been started prior to incarceration, and nearly no access to gender affirming surgeries. There are additional health concerns, but I think it would be the work of an entire PhD to discuss all of these. So kind of in brief review, the rate of sexually transmitted infections is much higher in incarcerated populations. In one study, 11% of women who were incarcerated were diagnosed with chlamydia and another 3% with gonorrhea, in addition to 1.3% who were known to be infected with HIV. Mental health and substance use disorders are really common in incarcerated patients, with 70% of women in state prison and jail meeting criteria for substance dependence or abuse, not including tobacco use disorder. And dependence is more common actually in women than men. Many patients also have experienced physical and sexual abuse within and without the justice system, and many report history of reproductive coercion. ACOG has put out a practice bulletin regarding the health of patients experiencing incarceration. These are the recommendations from ACOG, many of which we've reviewed. Primarily doing appropriate reproductive and sexual health screening, including screening for STIs, cancers, and osteoporosis. The recommendation is that patients in the carceral system administered vaccines, have the same access to preventive health education, access to mental health treatment, access to menstrual products, treatment of menopause symptoms. Also, the recommendations include the ability to access contraception, to initiate contraception if it's desired, and to obtain emergency contraception when it's needed. One important piece to think about is that the recommendation is to defer sterilization until after release. While patients in the justice system may desire permanent sterilization or desire cessation of childbearing, we know that the access and the inequalities within the system can result in reproductive coercion. And there's a significant history, as we've discussed before, of patients being unable to make their own decisions while within the justice system and being forcibly sterilized. For trans individuals, the recommendation is that they are able to continue hormone therapy, have access to gender-affirming surgery and safe housing, and that prison in general provides comprehensive gynecologic care and a trauma-informed approach to pelvic exams. We've talked a little bit about gynecology. I want to talk about the next topic, which is pregnancy in the carceral setting. ACOG has another specific set of recommendations around pregnancy and postpartum care, which start with assessing for pregnancy at the time of admission. We should screen patients who are not pregnant for postpartum and breastfeeding status and provide them with access to the tools that they need. Patients should have pregnancy options counseling that's not coercive and access to reproduction services. They desire to remain pregnant, they should have comprehensive perinatal care. They also should have access to treatment for mental illness, substance use disorders, alcohol use disorders, HIV. As we discussed before, all indicated vaccines should be given during pregnancy. They should have information about breastfeeding, lactation support, and support for postpartum care. The recommendation is that delivery services must occur in a licensed hospital with arrangements for transfer for high-risk pregnancy when that's needed, and that patients have both access to and counseling for postpartum LARC.
The number of incarcerated women rose 700% between 1980 and 2014. That's an increase of nearly 200,000 women. And more women in prison means more women giving birth behind bars. One of the most controversial practices that still takes place across the country is shackling women during childbirth.
But there's no reason to believe that women who are in labor are violent or pose a threat.
Teresa Kleinhaus is a civil rights lawyer representing more than 40 women who were shackled during childbirth at the Milwaukee County Jail.
So many of the corrections policies we have in the United States are really modeled from a few generations ago when many fewer people were incarcerated. The people who were incarcerated were much more violent and they were male. And then you apply those principles to a 20-year-old woman who's in jail for retail theft and 9 months pregnant, and it just makes no sense.
On the federal level, shackling during childbirth is restricted by just about every agency: the Federal Bureau of Prisons, Department of Homeland Security, U.S. Marshals, and Immigration and Customs Enforcement, to name a few. But more than 86% of U.S. prisoners are in state prisons. New York is one of 21 states that have laws restricting shackling during childbirth. Despite that, a 2014 survey found 23 of the 27 women who gave birth in New York prison since 2009 had been shackled anyway. There have been similar reports of non-compliance in Illinois, Nevada, and Pennsylvania. In Wisconsin, where Kleinhaus has represented multiple women in cases against the Milwaukee County Jail, there's no law banning the practice.
There is no police brutality in the United States.
Shackling was even defended by Milwaukee County Sheriff and controversial cable news commentator David Clark. But Kleinhaus disagrees.
Well, what we found in the Jane Doe case, she was also restrained, that inmates' midwife requested that the restraints be removed because midwives know that women in labor are focused on bringing a healthy person into the world and surviving a really hard experience, and their focus is not on hurting anybody or escaping from anything.
Despite legal action, Milwaukee County Jail at this time has no plans to change its shackling policy. Determining how many women are restrained during childbirth or just figuring out how many pregnant women are incarcerated is a guessing game. While the Bureau of Justice Statistics count how many women are in prison, there is no current data on the number of pregnant inmates.
I wanted to spend a little bit more time talking about this issue of shackling in pregnancy. I'm going to start with some statements that have been made by some governing bodies you may know. ACOG has stated that they strongly oppose the use of restraints in pregnancy, labor and delivery, and the postpartum period. The AMA says that no restraints of any kind shall be used on an inmate who's in labor, delivering, or recuperating from delivery unless there are compelling grounds to believe that the inmate presents a serious risk of harm to herself or others, a flight risk, and if someone is in labor, only the least restrictive restraints necessary to ensure safety and security should be used. The UN Committee Against Torture, in a statement that discussed rights violations within the incarceral system in the US in general, specifically pointed out that the committee is concerned about the treatment of detained women in the United States, including incidents of shackling of detainees, and recommended that the US adopt appropriate measures to ensure that women in detention are treated in conformity with international standards. With this many statements about the sort of role of shackling in pregnancy, you would think that there is laws in the state. But we look at this map that's available on the ACOG website. It looks at where there are laws against shackling, and you can see that Wisconsin doesn't have one. Our neighbors, Illinois and Minnesota, do. Iowa and Michigan at this point do not. In the United States, 37 state statutes and DC currently restrict the use of restraints for limited duration during pregnancy. The recommendations from ACOG are that the ideal protections for pregnant patients would restrict the use of restraints during pregnancy, labor, delivery, and postpartum, including in transit. Would give medical personnel the authority to have restraints removed. It would require corrections personnel to remain outside of the delivery room for privacy reasons, require written documentation by corrections personnel on the use of restraints, and specifically apply to juveniles. I'd like to give a patient who's experienced this the chance to talk about her experience.
My name is Maria, and I was incarcerated at Bedford Hills when I was pregnant in 2010. I just had a doctor's appointment to get induced. And it was the same thing, the hands and the feet. You can't even climb on the bus. They gotta help you to get on the van because you can't even lift your feet. They unshackled me and they cuffed one of my hands to like the metal of the bed. So I was like that the whole time. Even without getting induced, I started to feel the contractions and I started to feel like my daughter was coming out. They still had me cuffed to the bed. Like when I had to push, I was pushing, holding the metal because I was cuffed to the side. Even though they seen it that I was in pain and there was officers there and, you know, I couldn't go nowhere, but they just never even thought about it. They didn't even remove my cuffs for me to hold my baby. You know, I had to hold my baby with one hand and it was only for like 2 to 3 seconds. Then they took my baby away and they finished with me and I went to the prison ward. They didn't even take my handcuffs off until after I was stitched up. The placenta was taken out, everything. So I was in the prison ward. And I didn't see my baby until like the next day. My name.
ACOG, in relation to all of these concerns, has put out a statement about the potential health risks that are associated with restraints. Restraints increase the risk of fall and decrease the ability of a patient to protect herself and her fetus. They impair the ability for us to provide appropriate assessment and care for patients experiencing abdominal pain, vaginal bleeding, and treatment of preeclampsia or eclampsia. As we know, pregnant patients are at increased risk of venous thromboembolism, and shackles and bed rest that are associated with that make it difficult for patients to ambulate and increase their risk of VTE. With the edema that occurs, especially at the end of pregnancy, shackles may be too tight. Shackles add to the discomfort of pregnancy, which ACOG states is inhumane. And shackling interferes with the ability for us to have a normal labor and delivery. It impairs ambulation during labor, impairs management of shoulder dystocia or hemorrhage, impairs ability for intrauterine resuscitation and ability to proceed with urgent cesarean delivery if one is indicated. And it inhibits bonding and breastfeeding. One thing that we think about is the interactions that patients have while on labor and delivery. A survey was recently performed to look at the perspectives of perinatal nurses, national survey looking at members of an obstetric nursing organization. 75% of people who responded, nearly 900 people who'd responded, have taken care of pregnant women while they were incarcerated. Only 9.7% had reported ever feeling unsafe, but 82.9% reported that patients were shackled sometimes to all of the time. Another 12% said that patients were always shackled. When they were offered the opportunity to discuss why patients were shackled, the first and main thing many people said was it was adherence to rules or protocols. 33% of respondents said that the only reason to shackle a patient was because of a protocol that existed. There are additionally concerns about risk of flight, risk of harm to self, and risk of harm to others. So the question is, what next, right? This name of this talk is From Correctional Care to Correct Care. We've had a chance to discuss what care looks like now. And I want us to have an opportunity to talk about what care should look like in the future. As we discussed, in Wisconsin, there's no law restricting shackling. This has actually been a topic of advocacy. Fortunately, in this residency over the last few years, we've had a lot of opportunities to talk about advocacy, about ways to do it. And we've had a lot of examples, people within our department being able to access our congressional leaders. For those of you who haven't already read it, I highly recommend Dr. Buttigig's talk, which is available on YouTube, from her grand rounds last year. In the state of Wisconsin, in the 2017 to 2018 cycle, there was a Assembly bill and Senate bill that was brought forth to resist shackling for patients who were incarcerated. It passed the Senate Committee on Judiciary and Safety, was referred to the Committee on Corrections, but failed to pass by the end of the season. Again, in the 2019-2020 season, the Senate bill was brought forward relating to the treatment of pregnant or postpartum persons in prison and county jail. In fact, the advocacy that Dr. Buttigieg talked about was included presenting or speaking at this hearing. It was referred to the Committee on Judiciary and Public Safety, but failed to pass in April of 2020. We've talked a lot this year in the last few years about advocacy and the role that it plays. And it's disappointing that we haven't been able to achieve more at the state level. When I was thinking about ways to move forward, I thought about the reason that I cared about this in the first place, thinking about the patients that we're taking care of. And I think that allowed me to refocus in the wake of what has been, recent disappointments. I have one more patient story I'd like to share.
I was shackled was when I was 4 months pregnant. I was at Orange County Correctional Facility and I was going to court. And they were shackling me and they was making the shackles around my waist very, very tight. And I kept thinking to myself, like, how could they make it so tight? Like, how would I have room to breathe? I had the black box and then I was shackled to the other females that was going to court also. So I had ankle shackles on too. So it was very hard because I have long legs. So I have to take shorter steps because my strides are usually longer than people that are shorter than me. So it was constantly hard because if I move wrong, I will fall, and I was constantly falling and I was pregnant. So finally, when I got to the hospital, the correctional officers was arguing with the doctors about privacy because they were literally standing in the doctor's way when the doctors was trying to have me push the baby out. And it was just a traumatic experience. I didn't have any other choice but to allow them to stay there. The doctor was very upset about the fact that they were standing there. So they was asking me questions like, well, do you have a problem? And I'm like, thinking to myself, like, this is a trick question. Because if I say yes, I feel like you're gonna treat me harsher than what you're already treating me. So I was kind of like saying anything. I didn't know what else to do. So I didn't say anything. Like, I just was ignoring the doctor and the correctional officers. But I remember for the first visit for my child to go see the doctor, they had me shackled, handcuffed, black box, and I had to carry my daughter in her car seat with the base on it. And I kept thinking to myself, like, please don't trip, please don't trip. And the next thing I know, I trip. I dropped the car seat and the shackles was cutting into the back of my ankle. And all I could think was this, I knew this was gonna happen. And how can anybody allow something to happen like this? Like, I know I made a mistake, but this is a totally different punishment that nobody deserves.
One of the pieces that's come up in this patient's care is a question of how we as medical providers interact with patients who are in custody.
Shackle.
A study came out recently looking at trainee perception of health inequity in incarcerated individuals. And since this is what brought me to this topic in the first place, I think it's important to spend a little bit of time looking at this. This is a cross-sectional single institution survey of general surgery trainees in a Midwestern academic program that's not ours. 63% of them have operated with an armed guard in the OR with them. 65% of people have cared for a patient who was intubated and sedated, but still shackled to the bed. 75% have had a trauma patient that was questioned by law enforcement during the primary and secondary survey. A quarter of them reported being unable to prescribe all the medications that a non-imprisoned patient would receive for the same conditions. Nearly half were unable to arrange the appropriate outpatient follow-up, whether that was with PT, OT, the patient's PCP, or a consultant due to incarcerated status. And just about half believed that patients who were incarcerated had received substandard care. This survey had an opportunity for respondents to include some free text answers. I've included some of them here. One said, I think it's highly unfair that patients don't get to discuss any major medical conditions with their family members like any other patient has the right to. Another said, I think it's bull that patients who are prisoners are unable to contact their family, and that we as healthcare providers are also unable to contact their family with any updates. Most compellingly, someone said, I took care of an imprisoned person with multiple significant comorbidities who was transferred in for surgical care, but on arrival, surgery was deemed futile. We were not allowed to call this person's kids or spouse to say goodbye, and they died alone with the guard outside their room. We talk a lot in medicine about patient privacy. In HIPAA, which everyone's familiar with, we take steps to limit PHI disclosure to the minimum necessary to accomplish the intended purpose. The original proposal for HIPAA actually excluded inmates, but due to concerns for assault within the correctional facilities, if patient privacy wasn't protected, the final act includes inmates under the protections. However, there are exceptions in HIPAA for hospitalized patients, and a hospital may disclose PHI to a correctional institution or an official under certain circumstances. However, we know that there are frequent breaches of patient privacy in the presence of custody officials. One study surveyed physicians on their practice and the way that they handle patient interviews and physical exams in the presence of custody officials, and 95% had a breach of patient privacy. An appropriate move is to ask patients for consent when you're discussing PHI, or asking officials to move out of hearing range. Thinking about the ways in which we have cared for patients, I wanted to take a look at the policies governing our behavior. I took a look first at the UW policy 1.2.9, which looks at the care of patients under legal custody. The first sentence is that UW Health will treat all patients under legal custody at the same level of care as all other patients, and providing an environment supporting patient dignity and safety. It has provision for where we provide care within the UW system, including that inpatient and ambulatory care are only provided at University Hospital, at AFCH, specifically University Station Ophthalmology, and as we are familiar with, Union Corners Obstetrics. If as a physician or provider orders restraints for clinical care, those should be governed under the usual practice of restraints and seclusion within the UW system. Any additional restraints, such as handcuffs, shackles, segregation, should be the decision of the law enforcement officer. And if clinical staff have concerns that the patient's healthcare needs are compromised, then they should notify the attending provider to discuss, and then that person may request that the officer remove or modify the forensic restraints. There is a workflow within this policy for how to manage concerns and disagreements between the medical team and the custody team. Of course, as we all know, we take care of patients in multiple facilities, and looking specifically at the Meritor policy, there are a few sort of similar pieces. Inmates are guarded at all times within Meritor by the correctional or jail facility guards. There's no provision for replacement of these personnel by anyone on the Meritor staff. Metal handcuffs are the responsibility of guards and do not constitute clinical restraints. In the same way, patients who require restraints for medical purposes need them to be ordered under the normal medical restraints system. Inmates have the right to consent or refuse treatment. This policy includes notification of the facility guards of the time and place of any scheduled procedures or test schedule off the units, but says specifically, as we've heard in our trainings before, that this information should not be provided to the inmate ahead of time. There is notification of security services and the correctional facility guards of discharge, and again says, do not inform the patient. One thing that I think is really interesting is there's actually another piece of guidance that's come out of the Meriter Hospital. This one in the Office of Compliance and Risk Management. This is a separate statement that's available on the hub discussing disclosure of patient discharges to law enforcement. While the formal Meriter policy, which was started, this policy number 13, quite some time ago, states that patients' discharge information should be provided to custody officials. This guidance states that if a patient is under arrest or is a prisoner, then a healthcare provider may, but is not required to, disclose to law enforcement that an arrestee is ready for discharge. But we're not obligated to delay or hasten discharge at the, to meet the needs of the custody officials. If the patient is not under arrest and is not a prisoner, then the healthcare provider may only inform law enforcement of the discharge if the patient has authorized them or if they're required to do so by a court order. It specifically states that verbal authorization by the patient is appropriate, but should be documented in the medical chart. This brings up a lot of circumstances that we've seen, for example, in triage or even on labor and delivery, where someone is brought in by custody officials but is not under arrest. And I think that it's important for us to remember that this guidance exists and to make sure that it governs how we treat our patients. So coming back to the question, what can we do? I think that what we have learned from this is that there are a few major categories under which we can group our patient care. The first is to practice respect for patients, to additionally provide patients in incarceration with the same care as other patients, and to work within the system that we have and make provision for equal care, even if it's more difficult, and not allow their patients in carceral status to limit our care. When we need to remember the specific concerns in this population as regarding all of the health concerns that we've discussed. In advocate, we recommend engaging in advocacy. This came up in 2017, 2018. It came up again in 2019, 2020. There's no reason that we can't push for this again in 2022, 2023. And then just when you're facing a clinical circumstance, make sure that you're assessing the policies that are related and to the patient, and allow yourself room to discuss with other clinical providers, to discuss with the hospital leadership, and discuss with the patient. I'm happy to take any further questions.
Great. Thank you, Dr. Tran. I'll open it up here to any questions from the audience. Feel free to unmute and ask, or type your question in the chat.
I just have a comment. One of the things that we can do is mobilize and vote, because the problem with these humane conditions, they're barbaric. And I actually practice still in Milwaukee part-time with approval by UW, and I still see people shackled. And so that, and these typically are, they don't have to be, but typically are Black and brown women, and they're treated inhumanely. And so that I think your generation, Doc, is going to have to decide whether you're going to stand up against all the injustice that's done to women right now, because it just can't be tolerated anymore.
Oh, go ahead, Kathy.
Thank you, Dr. Tran. It was wonderful. Did you look into the First Step Act? It's at the federal level. It does not apply to our county jails, but it has a very detailed change in how we treat pregnant women in Title V of the First Step Act?
I don't know very much about that. Do you want to tell us a little bit more?
Well, it goes through, not shackling, and and providing all the things that you're talking about, that you can't shackle even up to 12 weeks postpartum. And if you do, you have to have record of it, and it does give providers the right to request shackling for safety, which, as you mentioned, is rarely the case, if ever. But it details a whole list of things that has to happen, and then there's reviews of those cases if somebody is shackled. So on the federal level, there are things that are changing, and we've tried to, in those bills that you mentioned in Wisconsin, point that out to legislators. But the law enforcement organizations in our state have a very strong lobby, and they are just not going to bend. We've actually met with the leaders of those organizations, with their ACOG lobbyists, to try and explain why this is so wrong. I've also, and you can do this, called the jail nurse in Waukesha County when they wouldn't allow patients to have their medications because they only pass meds once a day. This is totally, inappropriate, and it's abusive. But I think we also look at the county level, and we need to attend county hearings if possible, to get some advocates on our side to help these situations and get the policies to change, because they are barbaric, and you pointed that out very well.
Thank you so much for your expertise and for your comment.
Thank you. Thanks, Luther, for your comment as well. And piggybacking on that, Dr. Brown, made the comment that it's important to also help mobilize our patients to be able to vote as well and get them to the polls. And she's provided in the chat here the Vote ER link. So.
Yes, an extremely important way that we can work to enact change. Thank you.
A couple of years ago, we had these little forms or posters that were up with some kind of QR code or something to get people to register to vote, like in the clinics. Is there a way we could get those back? Or I think some people even had them on their ID badge or as a button or something.
This is Melody. We did have those out in the clinic, and some of them were actually left in the clinic, but I can check on where they still are located. UW Health has said that we weren't allowed to actually wear the QR codes on our badges, but maybe we can get them to revisit that. They said it was a uniform violation, but I know some people had them in their pockets and were able to pull them out. But we can definitely order another kit. Those are called Healthy Democracy kits from the National Vote ER. We got about 10 of those for free last year. I can look into getting more.
Yeah, it's another election year, so it's a good time to get them out.
Right. I was going to say exactly that, Dr. Anthony.
I'll just mention another aspect of Wisconsin that has a cocaine mom law, which allows anyone, family members, social workers, nurses, to report a person who's pregnant and using substances, or even if they've stopped using, and they can be forced into treatment or put in jail if they deny that treatment. Oftentimes it's very far away from their home and may not be necessary. It was found unconstitutional. We're trying to get that law repealed. We've got a group that's working on that with National Advocates for Pregnant Women. But we talk about restorative justice. And if we expect people to go into jail and then come out and not be, going back to those same behaviors, we have to treat them in a way that's going to allow that. We don't give them mental health treatment in the county jails most of the time. They don't get substance use treatment, although some now are providing buprenorphine, but it's very spotty. And as you mentioned, they have different service providers for incarcerated women. So we're making it almost impossible. I had a woman who had a very, very high risk pregnancy. I won't go into all the details, but it was probably one of the most high risk pregnancies I've taken care of. She had a classical C-section history, was twins, and she had a cerclage. She delivered at 25 weeks. She went back to the Huber facility after delivery and had no transportation, no housing, no money, no job. And she was walking back and forth from the Huber facility to the hospital to be with her twins and making every effort. Oh, and by the way, she had a heroin addiction that was totally untreated, despite every effort we had during the 25 weeks to try and get them to treat her. And we wonder why there's such a high recidivism rate. And now we've abused them even further. And it's just impossible for these people to recover. And it's, we're just actually setting them up for death. And we see that on maternal mortality review team, that after delivery, if they've been abused like that in jail or not treated, that there's a high rate of suicide and or overdose and death.
Yes, I think there's a lot of work for us to do within our own state. Absolutely.
Well, the problem is you're dealing with one of the worst incarceration disparity states, if not the worst in the nation. And so that you really have an uphill battle. I call it the just us system for Black and brown society that thinks that we should basically let people like insurrectionists go, but we lock Black people up for stealing a candy bar because they're hungry in a store. But you can trample police officers, all that kind of stuff. I'll give you a year in jail. But a Black person do something, we'll give you 5 years in jail for just stealing a candy bar. And they did look at this in Cook County, and we've had the same sheriff for a while, Tom Dart. And about a third of his patients at least have mental illness. And like he said, he'd rather spend time with the officers taking them to their psychiatric visits, because that would be more beneficial to them in the long run than incarcerating them. And he's like, there's no way in the world we should have somebody in jail a year because they can't pay bail because they stole a candy bar because they were hungry. And so, and I'm going to tell you, think about some of the things that maybe some of us have done that we've gotten away with. Now, I don't drink while we drive, but if you ever drink while you drive, that's against the law. And so there's some things out here that more well-to-do people get away with that less well-to-do and less well-connected people don't get away with. And so that we need to stop the basic disparities that we have at how we see. Why don't you go look at it? I took a look at it the other day, the FBI crime statistics. Okay, and I think they only go up to 2018 or 19, and see the differences about what you perceive of crimes and what you perceive of people committing the crimes and what your mind is thinking of who's committing those crimes. You should really look at them. They're astounding.
Thanks, Luther. Really important points there. Looks like there's one last question here, maybe that will, Vienna, I don't know if you came up with this. It's somewhat related, but not exactly, but if you came across this in any of your research, Maggie asks, are there any consequences to consider when ordering a UDS on a patient in triage? There are times when it's medically indicated, but are there any consequences for pregnant patients?
That's a really good question, Maggie. When we think about consequences, I think there's a couple of main categories that we have to consider. One is legal consequences. We don't, as a matter of PHI, we don't report if a patient has a positive UDS. However, if a patient is pregnant and has a positive UDS, that does often trigger a CHS report, and social work come and see the patient, and in many cases that in some cases that will end up being referred to the local child and protective, like child health services department.
Great, thank you. Well, lots of great.
So I think what they're trying to get at too is you can't really just do, hello?
Yeah, you're kind of breaking up there a little bit, Luther.
I was gonna say you can't just get a on a pregnant patient without, and ACOG actually says, I think I'm breaking up.
Yeah, I think
Yeah,
you're.
I was gonna say, what you have to do is go look at the Supreme Court decision on drug screening and pregnancy. You cannot just get a drug screen without their authorization while they're pregnant.
Yes, thank you. That's an important thing I didn't mention. Thank you, Dr. Gaston. I want to thank everyone for allowing me to be here today. I want to thank everyone for the really robust conversation. I'm going to thank Dr. Hartenbach and Dr. Rice, who allowed me to be here. Obviously, our current leadership, Dr. Spencer, Dr. Peebles, and Dr. Kelly. I want to thank this entire department for all of the mentorship and assistance. Especially want to shout out Dr. Adams, who connected me with Dr. Hartke, who gave me a lot of the information that I use as the backbone of this talk. I want to thank all of my co-residents for all of the work that they've done in allowing me to thrive in the midst of residency, with a special shout out to, of course, my class. I want to thank also my family and friends, some of whom woke up before 6 o'clock in their local time in order to listen to this, and some of whom are listening in class right now. Thank you very much, everyone.
Great, thank you, Dr. Tran. Really great talk today. Thank you everyone for joining, and have a great day.